All right, today we're going to do a deep dive into a really critical technique, one for managing those incredibly challenging proximal tibial fractures. So here's our game plan. We'll start by looking at why these fractures are such a headache. Then we'll introduce the Polar screw, which is just an incredibly elegant solution. After that, we'll walk through the placement playbook step by step. We'll look at the evidence, what the studies actually say, and then wrap it all up with the key clinical takeaways that you can put into practice. So let's kick things off with the problem that, let's be honest, we've all struggled with in the OR. That inherent instability you get with proximal third tibial fractures, especially when you're trying to nail them. You know, the anatomy itself is really working against us here. I mean, look at this diagram. You've got this huge, flared-out, trumpet-shaped space in the metaphysis. Then you try to stick a much narrower nail through it. It's a classic size mismatch. There's just all this empty space, which lets the nail wobble and drift, and that almost always leads to those two deformities we all dread seeing, valgus and procurvatum. And this is what's really staggering, just how often this happens. The literature is crystal clear on this. If you're just using a nail by itself, studies report malreduction rates as high as 84%. I mean, think about that. That's a massive failure rate, and it tells us we absolutely need a better, more reliable way to do this. And that, of course, is where the Polar screw comes in. It's such a simple concept, but it's an incredibly powerful tool that's designed to do one thing really well: control the nail's path and stop those deformations before they even start. So the genius of this thing is that it basically lets you build your own isthmus. You're taking that wide-open metaphyses, and by putting in a simple percutaneous screw, you create a narrow funnel. You're building a guardrail right where you need it, which gives you direct, precise control over where that nail goes. And this image just nails the concept. The name says it all, really. A pollard is just another word for a bollard, like the ones you see guiding traffic. The screw does the exact same thing. It physically blocks the nail and forces it to stay on the right path. It's just a beautiful, simple mechanical principle at work. Okay, so that's the what. Now for the how. Let's get into the nitty-gritty and walk through the clinical playbook for using this technique in the OR to get that perfect anatomic reduction. If you remember one thing from this whole talk, make it this. This is the golden rule. The whole technique boils down to this single principle. You always, always place your blocking screw on the concave side of the deformity you're trying to fix. Okay, let's put that rule into action. Take a classic valgus deformity. The apex of that curve is pointing out laterally, which means the concave side, the inside of the curve, is medial. So you place your screw on that concave, medial side. That screw now acts as a wall, a buttress. It stops the nail from drifting further medially and actually pushes it back laterally as you drive it down, correcting your alignment. And it's the exact same logic in the sagittal plane for that super common apex anterior or procurvatum deformity. In this case, the concavity is posterior. So where do you put the screw? On the posterior side. That blocks the nail from drifting backwards and forces it to travel along a more anterior path. Boom, fracture reduced. It's so consistent and predictable. And would you look at that? That's the end result we're all aiming for. When you leave that screw in place, it teams up with the nail and the bone cortex. What you've created is this incredibly stable 3-point internal mold. So you're not just getting a great initial reduction. You're building a construct with fantastic biomechanical stability for healing. So the theory is sound. The technique looks great on paper, but does it actually work in the real world? What do the outcomes tell us? Let's take a hard look at the data. I mean, just look at these numbers. The difference is absolutely staggering. We're going from a situation where, in the worst case, more than 8 out of 10 cases have a malunion, down to as low as 1% with Polar screws. This isn't just a small improvement, this is a total game changer. It's a paradigm shift. And it's not just about the x-rays. A brand new prospective study from 2024 shows that 92.5% of these patients get excellent or good functional outcomes. This is huge. It means that perfect-looking x-ray translates directly into a real, tangible benefit for the patient. And it's not just one study. A huge, systematic review from 2020 that pulled data on hundreds of fractures backs this up completely. They found incredibly low rates of non-union, malunion, and even a low need for secondary surgeries, all with a follow-up of almost 2 years. The evidence is just consistent across the board. Okay, let's bring it all home. What are the big things you need to remember the next time you're consented for one of these challenging proximal tibia cases? So, to recap, First, this technique just absolutely crushes malunion rates. It's a night and day difference. Second, always remember the golden rule. Screw on the concave side. Third, you're not just getting alignment, you're building a biomechanically superior three-point fixation construct. And finally, the evidence is overwhelming that this leads to fantastic outcomes for our patients. It is just a powerful tool in our arsenal. So this really leaves us with a big question, doesn't it? When you look at the strength of this evidence, the pure mechanical elegance of the technique, and the profound difference it makes in both alignment and patient outcomes, you really have to ask yourself, have we reached the point where Polar screws shouldn't be the exception but the standard of care for these fractures?